Hello everyone, today we will start head and neck anatomy OSCE, and please all should participate because this is new stations and all of us should participate to get the maximum benefit of the head and neck OSCE stations. And again, we study in this form like it is mock form. So I need you to know that we always study like that. Look at these questions, Karthik, and
Yes.
let me know if you are happy to proceed with these questions. Okay.
All right, sir.
Okay.
Sir, first question describing the anatomy of the
Describe the
thyroid.
anatomy of the thyroid gland. Brief description of the gland.
Okay, sir. Thyroid gland lies in the pretracheal fascia of the neck. The length ranges from C5 to T1. It has got a right lobe, a left lobe, and a middle part, which is the isthmus, the isthmus is located between the second and fourth thyroid cartilage. It is supplied by the superior thyroid artery, which is a branch of external carotid, the inferior thyroid artery, which is a branch of the thyrocervical trunk, and it is drained by three veins: the superior, middle, in the inferior thyroid vein, the superior thyroid vein, and the middle thyroid vein. They drain into the internal jugular vein, and the inferior thyroid vein, it drains into the brachiocephalic vein.
Okay, so such in brief, like two sentences. The the simple thing is to start with consisting of, so they are two loops connected by isthmus in the
Yes.
middle of the neck from C5 to T1 vertebra, and the isthmus is anterior to second to third tracheal rings, and it is surrounded by a capsule, which is surrounded by the pretracheal fascia. Nothing, nothing more. Okay, what is the function of the thyroid gland?
It is an endocrine organ and it produces thyroxine hormone. In addition to that, it has got certain portions of it which are dedicated to the parathyroid, which produce the parath hormone, and it has got C cells which
No,
produce
no,
calcitonin.
I'm asking about the thyroid gland. Thyroid is, we have two things, T3, T4, as you said, for regulating metabolism and the growth. And the parafollicular C cells of the thyroid produces calcitonin, which
Calcitonin,
is responsible for calcium
calcium
met-
reduction.
metabolism. Calcium
Yes.
metabolism, nothing more. Okay, so these are the first two questions answered in front of you. So thyroid gland, two loops connected by isthmus from C5 to T1, and the isthmus is lying in front of second to third tracheal rings, and the gland is surrounded by a capsule, and the capsule is surrounded by the pretracheal fascia. Okay, so what is the blood supply of the thyroid gland? Can you remember?
Yes. The superior thyroid artery, which is a branch of the external carotid artery, and the inferior thyroid artery, which is a branch of the thyrocervical trunk, which is a branch of the superior vein. This is the arterial supply, and the venous drainage is by the superior, middle, and inferior thyroid vein.
Okay, excellent. So simply superior thyroid from external carotid artery, inferior thyroid from thyrocervical trunk of the subclavian artery. And thyroid MA artery is 10% of the population, and it is mainly from brachiocephalic trunk or from common carotid subclavian or even from the aorta itself. So as you see here, this is a superior thyroid artery here is coming from external carotid artery. Okay. And here is the thyrocervical trunk is giving the inferior thyroid artery. So this is the inferior thyroid artery here. We can zoom in to find where is the thyrocervical trunk. This is the thyrocervical trunk, okay? From the subclavian artery, giving the inferior thyroid artery, okay? So regarding the next question, I'm going to ask you, what is the venous drainage of the thyroid gland?
There are three veins which drain the thyroid gland: the superior, the middle, and the inferior. The superior and the middle, they drain into the internal jugular vein, and the inferior, it drains into the brachiocephalic vein.
Okay, so excellent. So the simple is you are going to say that the venous drainage is carried by superior, middle, and the inferior thyroid veins, which form a venous plexus around the thyroid gland. Superior and middle veins drain into internal jugular vein, and the inferior in brachiocephalic vein. Cephalic, inferior. So superior and middle, there is middle vein, but there is no middle artery. Okay, so superior and inferior middle, superior and middle thyroid veins, internal jugular vein. Inferior thyroid vein into the brachiocephalic vein. Okay, so as you see here, we have this is the superior thyroid vein, and this is the middle thyroid vein. We will be here in this large internal jugular vein. Okay. And regarding this is a brachiocephalic, left brachiocephalic mainly will be draining the inferior thyroid veins, both of them in the left brachiocephalic. Remember, inferior F, left brachiocephalic F. Okay. Do you know anything about the neck veins? The neck veins. What do you know about the neck veins? It is a complicated question, but I need you to understand that this is two anterior jugular veins run downward from the chin, one finger breadth from the midline, and it will be lateral and extend from the sternal end of the clavicle and passes under the sternocleidomastoid to drain into external jugular vein. Okay. And both of the veins will meet in the jugular arch above the manubrium sterni. This is the anterior jugular veins. Simply, external jugular vein, very important to know the surface anatomy of both external and internal jugular vein. The internal lies superficial to sternocleidomastoid, not like this. This is deep to sternocleidomastoid. So it extends, represented by a line that starts just below and behind the angle of the mandible and runs to a point close to the lateral extent of the junction of sternocleidomastoid with the clavicle. Okay, so this is the external jugular vein surface anatomy. Okay, the external jugular vein can be distended if venous pressure is raised, like performing Valsalva maneuver. Okay, and by supraclavicular digital pressure, or if the vessel kinked. The big one, how the internal jugular vein will be formed. The internal jugular vein, as we discussed last lecture, it is coming from sigmoid sinus and the jugular foramen when it be joined with the inferior petrosal sinus. Runs from this jugular foramen deeply in the neck, in the carotid sheath, and it is similar surface markings to described in the common and internal carotid arteries, represented by a broad band from the lobule of the ear to the sternoclavicular joint, where it joins the subclavian vein. This is a big one, coming from the jugular foramen, which is deep here, not apparent, then enclosed in the carotid sheath, ascend very deep until reaching behind the sternoclavicular joint where it will be joining the subclavian vein. Very nice. What is the lymphatic drainage of the thyroid gland? What is?
The paratracheal lymph nodes.
Okay. I need you to extend the answer a little bit, just to say the pretracheal lymph nodes and deep cervical lymph nodes as well. Deep cervical lymph nodes. Okay. What is the complications of surgery to the thyroid gland?
The complications can be divided into immediate, pre-immediate post-op, and delayed post-op complication. In case of immediate post-op, the first complication, what we may say, is a subcapsular hematoma or a bleeding which may be compressing the airway. Then we, in the delayed complications, we may be seeing nerve injuries such as of the recurrent laryngeal nerve, or we may be seeing tracheomalacia if it is a large goiter which we have operated and it is showing on wound infection and seromas and these kind of things.
Okay, so I need you to be very like nutshells, the answer in a nutshell, okay? A minute, we have new attendee. I don't know why, like, yeah, but okay.
The, compli- the complications can be immediate and it can be delayed. The immediate complications are bleeding, if the bleeding, which is an hematoma formation. The delayed complications are wound infection, seroma formation, scar formation, and nerve injury. There may be hypocalcemia, which may be seen in the immediate post-op period and in delayed post-op period. And the hypothyroidism can also be seen at a later stage.
Okay, and regarding the replacement therapy, if it's total thyroidectomy, then we can require uh, long life replacement therapy, right?
Yes.
Okay, so just I will make it in brief. After Karthik will be Mr. Vayo, and after Vayo will be Mr. Dafar. Okay, so simply as you see in front of you, these lymph nodes, as you see here, there are pre-laryngeal lymph nodes, submental lymph nodes, submandibular, just to remember, and these are along the sternocleidomastoid surface anatomy, deep cervical lymph nodes, and these are the paratracheal nodes, and these are pre-tracheal, pre in front and para just adjacent. So this is the lymphatic drainage. What is the complications? Pain, bleeding, hematoma formation, seroma, infection, scar, nerve injury. The superior laryngeal nerve injury will be damaging the cricothyroid muscle and loss of high-pitched voice. Recurrent laryngeal nerve, difficulty in phonation and airway obstruction if bilateral. Hypocalcemia and need for long-term thyroid replacement therapy if it is total thyroidectomy. What is the nerve supply of the larynx?
Larynx is supplied by two nerves, superior laryngeal nerve and recurrent laryngeal nerve. They are both branches of the vagus. The superior laryngeal nerve provides sensation above the vocal cords, above the glottis, and it supplies the cricothyroid vocalis muscle. The recurrent laryngeal nerve supplies all the other muscles of the intrinsic muscles of the larynx, and it gives the sensory supply below the vocal cords.
So simply, superior laryngeal nerve divides into external and internal. Internal is sensory to the laryngeal mucosa above the vocal cords here. Okay, this is the internal one. And external is X thyroid, X cricothyroid. So external cricothyroid. So again, superior is divided into internal sensory above vocal cords, external to cricothyroid muscle, which is tensor muscle of the larynx and a cord adductor. The recurrent laryngeal nerve, it is the same as inferior laryngeal nerve. It is the same name. This is supplying the mucosa below the vocal cords and the remaining internal laryngeal muscles. Okay, for the thyroid lump, you should investigate any lump in your body, including breast and thyroid, via triple assessment. History exam, so history examination, imaging, biopsy. So history examination and imaging using ultrasound and biopsy using fine needle aspiration cytology, which might not be uh, well uh, well enough for medullary thyroid cancer or to demonstrate the follicular type cancer. So hemothyroidectomy will be an alternative method as a biopsy. Don't forget TFTs, thyroid function tests. Don't forget thyroid autoantibodies if you suspect any hyperactivity. Okay, and flexible nasoendoscopy to assess for recurrent laryngeal nerve function and the vocal cord movement by this one, flexible nasoendoscopy. What is the most common thyroid cancer? We said 85% or 80% is papillary thyroid cancer and more common in women in third to fourth decades of life. And papillary is characterized by lymphatic myths. Lymphatic myths. Okay, so keep going like this. What other types of thyroid cancer? We don't forget from part A. We have medullary, we have mainly papillary, then follicular, then medullary, and anaplastic and lymphoma as well. So 5 things. Papillary is the main one with good prognosis. Follicular, early hematogenous spread, and medullary can be sporadic and can be of men type 2A syndrome or men 2B syndrome. Also, don't forget that calcitonin is used for follow-up of the medullary thyroid cancer. Anaplastic is very aggressive, rapidly growing tumor, and it is of the bad prognosis. Okay, so don't forget these ones. Okay. What is the investigation used to follow up thyroid cancers? This can be asked always, but we always link pathology with the anatomy because we think anatomy, then pathology, always like that to connect the areas of the specialties in your brain. So serum thyroglobulin, T4, TSH, calcitonin, antithyroid or antithyroglobulin antibodies, and carcinoembryonic antigen. Okay. And this is thyroglobulin is only made by the normal thyroid cells or the well-differentiated thyroid cancer cells in papillary and thyroid cancer. The parafollicular C cells secrete carcinoembryonic antigen, which is a glycoprotein and is recognized as a tumor marker for medullary thyroid cancer. This is carcinoembryonic antigen. Regarding the parathyroid glands, I need another one. Thank you, Karthik. Go on. Keep going. The anatomy is very nice to pick all of its questions. Vio and Daf, I will open the mic for you, both of you, just to make it uh, competitive.
Okay.
Okay. Thank you, Karthik. Go on, Dafar, if you are here.
Yeah, I'm here.
Okay, that's excellent. Okay, so look, this is the parathyroid glands. Away from these questions, you have from 2 to 6 parathyroid glands, mainly 4, and describe how the parathyroid glands are subdivided and what is the normal location, what is the embryological origin, blood supply, function, role of calcitonin, signs of hypocalcemia, and being asked last exam for Dr. Ola and Isra as well about the 2 signs you should remember with me. Okay, so I will start with the first question for you. What is how the parathyroid glands are subdivided?
For me, obvious.
For anyone.
Okay.
Any one of you.
Parathyroid is 4 glands, 2 in each side, posterior to the thyroid gland, and this is subdivided. The superior parathyroid gland is separated. It's originated from the 4th bronchial arch, and the inferior parathyroid gland It is originated from the third with the thymus, with the third branchial arch with the thymus.
Okay, which is more fixed in position, embryologically, superior or inferior?
This is with the fixed.
Fixed in their position, like constant position in the population, which is more constant,
inferior.
the superior one. Why? Because
Oh,
you couldn't find the inferior one, you can find them where?
in the chest,
Where in the chest?
in the thymus.
Yes, which mediastinum? Superior, inferior, anterior?
Superior mediastinum. Yes.
Okay. So just to answer these questions, we said there are 4 parathyroid glands, 2 in each side of the posterior surface of both of one thyroid loop. So they are superior glands and inferior glands, 2 and 2. The superior are more constant in position compared to the inferior. It is like from, as you said, from the 4th pharyngeal pouch, and the inferior from the 3rd pharyngeal pouch with the thymus. We said inferior with the thymus from the 3rd. TH, remember this mnemonic. So superior is superior, so number 4, so 4th. But inferior with the thymus because it is inferior. And if you couldn't find it, you can find it in the superior mediastinum with the thymus, because both of them are embryologically the same origin from the 3rd pharyngeal pouch. What is the blood supply simply of the parathyroid? Do you know?
The blood supply for the parathyroid gland, it is taking from the inferior thyroid artery.
From inferior thyroid artery. Okay. And regarding the functions of the parathyroid gland, what is the function?
The parathyroid gland will secrete the parathyroid hormone, which regulated the calcium metabolism in the body.
How this could be, like increased level of parathormone levels, increase the absorption of calcium from the gut, and reabsorption from the kidney, and osteoclastic activity from the bone. So 3 ways to increase the calcium parathormone. Increase absorption from gut, reabsorption from kidney, and classed بتكسر, classed catabolic.
Yes.
Okay, classed osteoclastic activity in the bone to increase the resorption of the bone, to release more calcium in the blood, and also will play a role in phosphate metabolism. This is the parathormone. Okay, regarding the calcitonin, what is the role of calcitonin on the parathyroid gland?
The calcitonin, it is reverse the action of the parathyroid hormone. So it is inhibited reabsorption of the calcium from the bone, and decreased excretion from the renal system.
Okay, so I will tell you. This is very nice question. When I increase as a parathyroid hormone, so the parathyroid will tell me, your hormone go on, increase the calcium. So once calcium increase, this will increase the calcitonin increase from the parafollicular thyroid C cells, parafollicular C cells of the thyroid. Okay, then there will be reduction in the amount, as you said, of the calcium absorbed by the gut and reabsorbed by the kidney, and inhibits osteoclastic activity, as you said, so preventing bone resorption. But however, like parathormone, calcitonin reduce the amount of the phosphate reabsorption in the body. So very nice one. Me, as parathormone from the parathyroid gland, I will increase the calcium by gut absorption, kidney reabsorption, osteoclastic activity increase. And I will decrease the phosphate. Then once the calcium increases, this will stimulate the calcitonin release, which will say, okay, I will try to reverse your action because I'm here to do this, and I will try to reduce the calcium absorption from the gut, calcium reabsorption from the kidney, and bone resorption. And also, I will be with you because I hate phosphate like you. So I will decrease phosphate reabsorption from the kidney as you do. Excellent. Okay, so next question is going to be what, yeah, the clinical signs of hypocalcemia.
Clinical sign of the sign, Jovistic sign, carbovidial Jovistic sign. It is tapping on the facial nerve, which leads to twitching, and also carbovidial spasm when they increase the blood pressure, sphygmometer blood pressure on the hand, which leads to the carbovidial spasm. Also numbness, spastic, and paresthesia.
Excellent. So circumoral hands and feet tingling and numbness, tetany, convulsions, two signs. So again, two, tingling, numbness of circumorally, hands and feet, tetany, convulsions, and two signs. Chuvistock, chew, just press over you to remember these ones, press over by this movement. Press over the tree in front of the tragus. This will tap over the facial nerve due to hypocalcemia. This will cause twitches of the facial muscles. Okay. So this is Chuvistock like this. Trousseau, remember tourniquet of the sphygmomanometer. So trousseau, tourniquet, but Chuvistock by pressing like that. Not to forget, been asked before last exam and before this in multiple exam centers. So trousseau sign is muscular contraction following inflation of the sphygmomanometer cuff for several minutes above systolic, both due to increase the neuromuscular excitability by the hypocalcemia. Okay. What is the investigation for the parathyroid gland enlargement?
So parathyroid gland enlargement, which should
First, you are afraid about to have adenoma, right?
yeah.
So if you are afraid to have adenoma, then you are going to have hypercalcemia. So you will measure bloods, electrolyte, parathormone, serum, calcium, urea, and electrolytes, and vitamin D level. Why? Because again, uh, the hyperparathyroidism is known as increase in the calcium, decrease in the phosphate, and you don't know what is the reason. Is it hypervitaminosis or hypovitaminosis D? So you measure calcium, urine calcium levels, and you will do ultrasound neck, and we don't think it is going to be beneficial. So the best is system EB parathyroid scintigraphy, system EB scan, and you are going to measure the bone density, bone scan, and MRI if you need to know the extent of the or delineating the anatomy. 80% or 85% it is adenoma, 15% it is hyperplasia, and only less than 1% carcinoma. This is the main reasons for the parathyroid gland enlargement. Okay, so adenoma also can be found by accident called incidentaloma. Okay. So now we are going to talk about the Atlanto-occipital joint, okay, and Atlanto-axial joint as well. Just have a look at this 3D anatomy to remember the Atlanto-axial joint. C1 atlas, this is the one. And when I remove this one, when I hide it, there is C2 axis. This is the axis or C2. Have a look, not to forget, because we have some questions next for the spine, okay? Again, we can repeat this for you just to enjoy. Here, there will be above here, this is will be the occipital condyles here. So it's called here, the occipital condyle. So it is called Atlanto-occipital joint. This is atlas, so called Atlanto-occipital. But this one here called the Atlanto-axial joint, because this is atlas and this is the one is C2 axis. This is the axis. And here some ligamentum, important ligamental structures. Okay, this is the transverse ligament of the atlas. This is the longitudinal band of the cruciform ligament, okay, of the dens. And from here, this is the anterior atlanto-occipital membrane, okay? And this is the C1 atlas, and this is C2 axis, and this is the fibrous layer of articular capsule of the Atlanto-axial joint. This is the one, okay? So don't forget, and this is our foramina transversalium. If anyone ready to participate in the next questions, please let me know. Toby, are you ready?
I can. Yes, I can try.
Yes, excellent. Okay. Okay, don't forget, this is the superior articular facet for the occipital condyle, for the occipital bone to rest here, the bone of the skull. So this is C1 atlas, and this is C2 axis. But here is C5 vertebrae, cervical number 5. Okay, so don't forget the difference. This is C1, C2, and this is other typical cervical vertebra from C3 to C7. Okay, so here we are, some questions regarding what are the characteristic features of typical vertebra, and how does C1 differ from typical, how C2 differ, and how C7 differ from typical cervical vertebra. So apparently we have C1 to 7, they are atypical cervical vertebra, and from C3 to C6 are normal or typical ones. Okay, and don't forget this structure here, this line here, and been asked last exam, and I shared it before in the old group. This is called one of the dural venous sinuses. Sorry, dural folds. Dural folds. We have a 3D version of them, so don't worry about them. So here you are. Is that regarding this, identifying the following features on this vertebra? Is it C1 or C2? This one, is it C1 or C2?
It's none of them.
Excellent. Thank you. Thank you. This is number one. Okay. What is this?
That's the vertebral canal,
Excellent. And what is this?
the vertebral body.
And what is this?
That's the transverse process.
No.
Oh, okay. That would be the pedicle.
There is a mnemonic I told you last, I don't remember the lecture, which is called LASP, LSP. Okay, if you remember.
Okay.
But no problem. Is that, I'm going to ask now, is that the pedicle, and this is the lamina, and this is the spine. So it is, this is the lamina, the long one is lamina, and this is the pedicle, and this is the body. Okay. So this is lamina, pedicle, and body. Okay. What about this hole? What about this hole? Vio or Tubi, if you are here.
Yeah, I'm here. Toby is here.
So what is this foramen?
Okay, the foramen transversorium for the
Excellent.
vertebral artery.
For the vertebral artery. Thank you so much. And what else you could differentiate? What is that one?
That's the superior articular facet.
Yes. Superior articular facet. And what is this one?
That's the spinous process.
Bifid
Bifid
spinous.
spinous process.
Excellent. Thank you so much. So what is the characteristic features of normal or typical cervical vertebra?
The normal or a typical cervical vertebra has a vertebral body that has the transverse process that contains the foramen transversorium, and it has a triangular vertebral canal and also a bifid spinous process.
So first look at the body. This is above, this is C1 and this is C2 and this is the typical one. Okay, typical one, we've got from C6 to C3 to C6 typical ones, characterized by broad body,
Yes.
okay,
Okay.
small and bifid spinous process, okay, and transverse process with foramen transversarium,
Yes.
and oblique plane of the facet. So see
Okay.
again, this is C1,
Yes.
this is C2, and this is the other one, the typical from
Typical.
C3 to C6. Look at the front, broad body.
Broad body.
From the front. From the back, bifid spinous process. Laterally, two other features. Transverse foramen or foramen transversarium with a foramen or transverse process with a foramen transversarium for the vertebral artery. And also oblique plan or plane of the facet joint surface. Okay, oblique
Okay.
plane. That's it. This is the features of typical cervical vertebra.
Vertebra.
Okay, now other questions. How does C1 differ from this typical one?
So C1 has no vertebral body. It has no vertebral body.
Excellent.
Yes.
Nobody.
It has a posterior tubercle and an anterior tubercle. It has no vertebral spine.
Okay.
And
Excellent.
yes, yeah, and it has a facet on the posterior surface of the anterior tubercle for articulation with the dens of the axis.
Okay.
Hello? Yes.
Okay, so we have from front, no body, no spinous process. Again,
Yes.
from the front and from the back, no body, no spinous process.
Yes.
Large kidney-shaped vertebral canal. You know why? Because the spinal cord is going to be enlarged, going for medulla, bones, and above. So it is going to be enlarged. So it is large kidney-shaped vertebral hole.
Canal. Okay.
Okay, and there is
Yes.
no spinous process or body, and this feature, the occiput.
Okay. Okay.
There are occipital condyles articulating
On
with
the
occipital bone of the skull. That's it. Okay, excellent. Thank you. Regarding C2, look at C2 and look at the other one. How this differ from that one?
Okay, C2
C2
has, yeah, it
on
has the
atlas, C2
odontoid,
axis.
yeah, axis, that's the axis.
Mm.
It has the odontoid process that projects upwards from the body. I think that's the major difference between C2 and others.
Okay, so I will say first, do we have a vertebral foramen here?
I can't see, I cannot see, but I think C2 should have. I don't know, I just think so. But it's not in the picture.
Not in the picture, no.
Yeah.
Okay. Is it having or no a foramen transversarium? Yes or no? I'm asking
I
you.
think it has, yes. Yes, yes, it has. Hello?
Okay, I'm asking them in the chat. I'm waiting for them.
Okay, okay.
There is or no? No, Dafar is saying no, and Nasrat is saying no. Okay.
Okay.
No, I haven't told you anything. So if you someone say yes and some said no, so it is 1 versus 1. What is the
Exactly.
anatomy of the vertebral artery? Because you said
Okay,
some said yes and some said no, and this is the vertebral artery. So what is the vertebral artery anatomy?
the vertebral artery arises from the subclavian artery, the first branch of the subclavian artery that
Vitamin
ascends
C and D,
through
so
the,
D vertebral. Excellent. Okay, yes. What will go from where to where?
okay, the vertebral artery enters the foramen transversarium of C6 cervical vertebra up until and ascends upwards through all other foramen transversarium to the C1 and exits the C1 foramen transversarium to cross the groove on the posterior arch of C1 and together with the other vertebral artery forms the basilar artery.
So the origin in the vertebral artery from the subclavian artery, and then 4 segments. Segment 1, pre-foraminal.
Okay.
Origin 2, the transverse foramen of C6. Then foraminal segment from transverse foramen of C6 to the transverse foramen of C2. So C2 got a foramen. And then Atlantic or extradural segment from C2, where the artery loops and turns lateral to ascend into the transverse foramen and hooks around the C1, okay, and will enter to into the vertebro-basilar system. Okay, so there is one there is foramen transversarium in the
C2.
C2. Okay. So now, so can you continue? What is the difference? So you said simply one sentence. C1 is different, C2 is different by the following.
Yeah.
See here.
Okay.
This is C2. Okay. So
yes.
No spinous, no bifid spinous porosis, not bifid spinous porosis.
Okay. Okay.
With a very characteristic feature, which is the odontoid big process, odontoid or big or dense of atlas. Dense of atlas is the instead of the body, nothing more. Okay, nothing more.
Okay.
Thank you so much. Now you don't forget the difference and you will see very clear. Okay.
Okay. Thank you very much.
Thank you. So just to revise them, how C1 atlas differs from typical C1. C1 atlas contains occipital condyles for articulation with the occipit of the skull and wide kidney-shaped vertebral hole without any spinous process or any body. No body front, no spinous process, large kidney-shaped vertebral foramen, and occipital condyles. This is the C1. It is atlas. C2 axis, okay, it is containing odontoid big like dens with no instead of the body and not the spine is not bifid. The spine
Okay.
is not bifid.
Not
Okay. Regarding C7, which is called, and I will ask you to identify it on yourself. So how does the C7 differ from the typical cervical vertebra?
The C7 has a long spinous process, and it also has a small foramen transversarum that the vertebral artery does not pass through.
Very nice. Very nice. So C7 called the vertebral prominence because it is containing long non-bifid spinous process. Long non-bifid spinous process.
Spinous process.
And the transverse process is well respected, large, but the foramen transversarium is very small and does not transmit the vertebral artery. The vertebral artery starts from above, which is C6.
Yes.
Okay, but it does transverse the vertebral vein. Very nice. Okay, very nice knowledge of the anatomy. Okay, which joint permits flexion and extension of the neck when you do lock to the ground and lock to the god, lock to the sky? So which joints permit the flexion? Which joint do the flexion and extension of your neck?
Okay. That's the Atlanto-axial joint.
No.
I'm not sure.
Okay,
Sorry.
I will come back to the video. If you see here,
Okay.
this is rotational. There will be rotation here to lock right and left here. But the occipital condyle will swing. 1 minute. The occipital condyle will swing here. So the occipital or atlanto-occipital joint is for flexion and extension. Okay? Is it not? So the occipital condyles will swing here. Okay? So when I ask you which joint for flexion, it is the atlanto-occipital joint formed by articulation of C1 atlas with the occipital condyle.
Occipital condyle. Okay. Clear, very clear.
And with what type of joint is the atlanto-occipital joint?
It's a pivot synovial joint.
It is
sorry,
atlanto-occipital joint.
Occipital. I think is it condyloid? Synovial.
It's condyle. So it is condyle.
Yeah.
So it is.
Yeah, condyloid.
Okay. Let's see. It is the atlanto-occipital joint simply is a type of between C0 or occipital condyles and C1.
Okay.
And the movement, we said flexion extension 1. You said it is ellipsoid. It is ellipsoid or it is same as condyle because it is condylar movement between the condyles. So it is synovial condylar joint. Excellent. Okay, and what about, because I need you to come here with the culture that not all the exam is in your hand. Try to expect, try to think, and see how it goes. Okay. Regarding the okay. Okay, what type of Atlanto-axial joint? What type of Atlanto-axial joint? Again, the Atlanto-axial joints are formed between the masses of the atlas and the axis, and they are gliding joints. So they are complex synovial joint, allowing the movement or the rotation of the neck. Okay, and they are pivot joints. Pivot. Okay. So it is a complex of three synovial joints between the atlas and axis. Why it is complex? You see here in the image. Okay, you see here, it's very nice because there will be articulation of the dens inside with other joints. So it's about three structures going. Okay, lateral paired lateral atlanto-axial joints classified as synovial joint between lateral masses of C1 and C2, and median atlanto-axial joint or atlanto-dental joint. This is a pivot joint type. Okay, so again, I will stop here. Okay, so see here, this is between the lateral masses of, this is atlanto-axial joint, this is a planar type synovial joint because there is only gliding here. But what allow the rotation is the articulation of this one as median atlanto-axial joint. So two lateral and one, so three synovial joints. One is plane or planar, and the median is a pivot one to allow rotation from the right and left. Okay, very nice. What prevents the excess rotation of the atlanto-axial joint? Anyone, if you look here, you will understand the question. Why you are not able to look behind you completely by rotation of your neck? Do you know why? If you look the image, this image, because of the presence of the alar ligaments. Alar ligaments. What alar ligaments? These ligaments connect the dens to the occipital condyles. Okay, this is the one. Okay, so they are above here because we'll connect the dens to the occipital condyles, preventing the excess rotation at the atlanto-axial joint. Excellent. Okay. What is the function of dens of C2 or the odontoid process? It is just rotate the skull, okay, to rotate the skull. This is the proportion of C2 that articulate as median atlanto-axial joint to allow rotation of the skull. Okay. What is the clinical, and this is very important question to be asked. The clinical, if I asked you, there is dense fracture, what is the clinical significance? Quadriplegia can result because the dens can severely affect the spinal cord. Okay. What is hangman's fracture? Hangman's fracture. Anyone knows? I will open the mic. Hangman's, Karthik, Tubi, Dafar.
Lateral body of T2 of C2. The lateral muscles of C2 are fractured and hangman's.
So it is fracture of both pars interreticularis of C2. from hyperextension and distraction type injuries. Very, very nice. I'm going to ask you now regarding this fault. What is this fault? Anyone
That's
know?
the tentorium cerebelli.
Excellent, thank you. What do you know about how many cerebral faults do we have?
You have 4.
Okay,
Flux cerebri, tentorium cerebri, flux cerebelli, and diaphragmatic cellate.
so we have falx. This is the falx here. You see, this is the falx cerebri, and this is falx cerebelli, separating the cerebellum from each other. Okay, this is falx cerebri, falx cerebelli, and one tentorium cerebelli from each one. So we have 3 because the tentorium is 1/10, so it's considered 1. Okay, and what is the value of these faults, dural faults?
The value for
The dural sinuses. Here we have the superior sagittal, inferior sagittal, and transverse, and here in the middle, in the confluence of sinuses. And this will impress over the occiput. This cross-shaped structure will impress over the occiput because here will be superior sagittal sinus, inferior sagittal sinus, and the transverse one. And here is the confluence. This will impress on the skull bone itself. Okay. Regarding the scalp, and the scalp is very, very important. Okay, because you know it is a type of layers that protect the skull from the outside of your body. Okay, anyone is ready to have the skull?
Yeah.
Yes. Yes.
Okay, the scalp. Okay, what is the scalp layers?
There is anyone?
Yes, anyone.
There is skin.
Yes.
Connective tissue.
Okay.
Aponeurosis.
Okay.
Loose areolar tissue. And the periosteum or pericranium.
Okay, so it is a scalp. So skin connective tissue, aponeurosis, loose areolar connective tissue, and pericranium. Excellent. Okay. Okay, just have a look again about these questions. The doctor who started, first you identified the layers, and what each layer from you've mentioned that the blood supply is running within.
Loose connective tissue.
And that's why, what is the clinical significance of that?
Clinical significance? It's got severe bleeding when there's any injury for the skull.
Excellent. Because of the looseness of this connective tissue, if there is bleeding, there will be large hematoma and profuse bleeding. 2 significant adrenaline can be given. And when you see, if you sutured someone with a scalp injury, you see a very large hematoma. When you press it, it goes out because the loose areolar layer is containing the arterial blood supply. Okay, so what is the blood supply of the scalp?
Blood supply of the scalp, superior orbital artery, superior tracheal artery, temporozygomatic, frontozygomatic artery.
I will say some branches from the ophthalmic, from internal carotid, and some other branches from the external carotid. Okay. So what is the venous drainage of the scalp? Is the corresponding names of the arteries and collected by facial and retromandibular veins, and retromandibular and posterior auricular vein, which will eventually drain into the external jugular vein. And don't forget, intracranially, they are connected with the diploic veins in the calvarium and the intracranial venous sinuses by valveless emissory veins. So what is the clinical significance of having such connection?
So any infection from outside, you can go through a missionary vein or by valveless missionary vein to the intracranial and cause severe dangerous injury.
Especially which area? Do you know what is the dangerous area of the face?
Between the two orbits and the nose.
Between the two angles of the eyes.
Two angles of the eyes.
Point and 2 points in the angles of the mouth.
Mm.
Because which veins connect? Look at this image. See, superior and inferior ophthalmic veins will be connected to direct with the cavernous sinus, and other facial veins will be connected to pterygoid plexus of veins, and at the end will cause cavernous sinus infection and thrombosis. Any infection in the dangerous area of the face. Okay. And as you said, the emissory veins of the scalp are with no valves, so scalp infections can cause dural venous sinuses, causing cavernous sinus thrombosis and infection. And also don't forget for the a dangerous area of the face. Okay, excellent. Other questions? What is the commonest lump of the scalp?
Sebaceous lump, because there are a large number of the sebaceous gland.
Okay, what is the sensory supply of the face?
From the trigeminal nerve, so it is dividing in 3 branches: ophthalmic branch, maxillary, and the mandible. Maxillary ophthalmic branch, it is to supply the face, upper eyelid, until upper eyelid, and the part of the nose. From the lower eyelid to the upper lip, it's maxillary, and below with that mandibular.
But apart from the angle,
except the angle of mandible supplied by the greater auricle C2, C3.
Excellent. What is the branches of the facial nerve within the parotid gland?
Okay.
Okay. Starting from above downwards.
Yes, excellent.
There will be the temporal.
Yes.
Zygomatic.
Yes.
Buccal.
Yes.
Marginal mandibular. And the cervical. So
2 zoobimotor cycle: temporal, zygomatic, buccal, marginal mandibular, and cervical. Okay, excellent. What is the structures that are attached to the styloid process?
There are muscles and ligaments.
Okay.
The muscles are the stylohyoid, styloglossus.
Excellent. So stylohyoid and styloglossus, stylopharyngeus, and 2 ligaments. Okay. So we have tongue, pharynx, and hyoid bone. So stylopharyngeus, stylohyoid, styloglossus, and 2 ligaments: stylohyoid ligament and stylomandibular ligament. This is the stylomandibular ligament. Okay. And this is the stylohyoid ligament. Okay. What is the muscles attached to the mastoid process?
Cleidocmastoid, posterior belly of digastric, splenus capitis, longissimus capitis also. Yes.
Okay, so the first one is sternocleidomastoid and posterior belly of digastric with longissimus and splenius, longissimus capitis and splenius capitis. What does the marginal mandibular supply, and what is its significance?
Depressed labii inferioris were depressed angularis speculi And mentalis.
So depressor libai inferioris,
Mm.
and depressor anguli oris, and mentalis, and at risk during submandibular gland surgery, and or carotid end arterectomy, and the result will be drooling of saliva while you are smiling, dropping of the corner of the mouth, and failure to smile. Why? Because of these muscles, the anguli, the movement of the angle of the mouth. Okay, what is a very nice slide? I like this slide because it is facilitating how to keep the facial nerve. First, the facial nerve is a mixed large motor root and smaller sensory component. The motor root arises from the facial nucleus in the pons and sensory from nervus intermedius. Then the whole two roots as one nerve enters the petrous temporal bone via the internal auditory meatus, runs course through the facial canal in the internal auditory meatus, and exits the skull through stylomastoid foramen. Stylomastoid foramen, between the styloid and the mastoid. Stylomastoid foramen. Then enters the parotid between the two lobes, superficial and deep. Within gives the pes and serenus, the duck leg, 5 branches, 2 zoomotor cycle, temporal, zygomatic, buccal, marginal, mandibular, and cervical. The abbreviated supply, sensory, taste, anterior 2/3 of the tongue, and somatic, part of external acoustic meatus and deep parts of the auricle. Visceral motor, parasympathetic, secretomotor to all salivary glands except the parotid. Also, all mucous glands associated with the oral and nasal cavity and lacrimal gland. Okay, so there are two root, motor and sensory. Okay, don't forget this. Branches before it exits the stylomastoid foramen, extracranial branches before it enters the parotid gland. So there are 4 branches before I come here in the stylomastoid foramen. Okay, nerve to stapedius. Okay, chorda tympani nerve, greater petrosal, and communicating branch to the otic ganglion. Again, nerve to stapedius, chorda tympani official, greater petrosal, and what is the significance? If I told you there is a fracture around the stylomastoid foramen, there will no be hyperacusis because nerve to stapedius already left the facial nerve before its exit from this foramen. So there will be no hyperacusis. This nerve will not be affected. There will not be any taste change in the anterior 2/3 of the tongue because this nerve is not being affected. Okay. What are the extracranial branches of the facial nerve before it enters the parotid gland? Post-auricular nerve, branch to posterior belly of digastric, and branch to stylohyoid muscle. These are just between its exit from stylomastoid and before entering the parotid, will give other extracranial branches, not sensory, but they are post-auricular nerve, not sensory like 2 zoo by motorcycle, but we have posterior auricular nerve. We said internal part of the auricle and part of the internal canal, as you see here, part of the external acoustic meatus and deep parts of the auricle, and branch to posterior belly of digastric and branch to stylohyoid muscle. What is the clinical significance of the course of the facial nerve? You are 23 attendee, Nasrat. You are raising your hand. I need you to participate. Excellent, thank you. So what is the clinical significance of the course? We said that the branches between superficial and deep lobe of the parotid are vulnerable to injury during the gland surgery. and also malignant tumors of the parotid, like which tumor?
It is pleomorphic adenoma. It's a benign tumor.
No, not pleomorphic is a benign. Not
Yes, and mucinous invasive carcinoma, I think this will be the malignant one, which is more involving the facial nerve.
adenoid cystic carcinoma.
Adenoid cystic
Warthin's
carcinoma.
tumor. Okay.
Yeah,
Adenoid cystic carcinoma or Warthin's tumor.
Warthin's tumor.
Okay. Okay. Regarding this picture, what is attached here? It is important structures. Okay. So can you tell me, without looking into this illustrations, can you tell me this part of a cadaveric specimen from the head and neck? And in MRCS OSCE, you know, it is all about pictures. Most of the centers now will give you pictures, okay, even a diagrammatic picture or cadaveric picture. So regarding this number 17, what is number
Internal jugular.
internal
Jugular vein.
jugular vein? Excellent. Regarding this cut muscle, number
Sternocleidomastoid cut.
sternocleidomastoid cut. Excellent. And regarding this one, this is
Sternothyroid.
sterno.
Sternohyoid,
It is above sternohyoid,
yeah.
but
The
this
below one is sternothyroid.
sternothyroid. And with what is number 24?
We are 24.
This is the
34.
separation between the two muscles
Yeah.
on the thyroid.
Right, this thyroid gland.
It is oblique line of the thyroid cartilage. Yes, this is a thyroid cartilage oblique line. What
Yeah.
about this muscle here?
This omohyoid.
Omohyoid. And this
Yeah.
is which tendon?
This is the lower part of omohyoid.
We have superior belly and inferior belly
Inferior.
connected with intermediate tendon.
Intermediate.
Okay. Regarding this one, number 15,
This is hyoid bone.
hyoid bone. Number 38, this is small muscle.
This is thyroid. This
Thyro, small
thyroid.
thyroid. And
Yeah.
32,
32. Sternoids come from sternothyroid.
sternothyroid. Excellent. So can you identify the infrahyoid strap muscles?
Yeah, it's divided as it seems like superficial and deep. Sternothyroid, sternohyoid, and omohyoid, and thyroid.
Very nice. Okay. So we have superficial and deep. Superficial are sternohyoid and omohyoid. The deep are sternothyroid and thyrohyoid. All by ansa cervicalis C1 to C3, apart from thyrohyoid by only C1. The action is depressing the hyoid and larynx during swallowing and speaking. Okay, thank you. Regarding this complicated photo, I'm going to ask you deep regarding each structure. Okay. Without looking to the illustrations, can you give me a clear idea about what is 43?
This is cut of the muscle, sternocleidomastoid.
Okay. What is number 16? This came in December 2018 in Cairo. This one, number 16.
This is part of ansa cervicalis.
No, this
Or
the cord.
It is a nerve, greater auricular nerve.
Okay, so don't forget two nerves, two cords parallel to each other at this level. One is lateral, superficial to sternocleidomastoid. This is number 16, a great auricular nerve. And the below one is below and medial, below sternocleidomastoid and medially. Spinal accessory to give the muscle.
Finally,
Don't forget, if you attended the lecture on the website, I think it was very nice, more than this, but no problem.
Yeah.
I will be staying with you. And what about number 11?
This is an artery going up from the. This is a branch of external carotid artery.
Okay, which one?
Okay, I don't exactly remember. So.
Okay, leave number 11 now. Come to number 48.
48. Where's 48, sir? 40. 48. 48. Yeah. This is this is posterior belly of digastric muscles.
48 is
Posterior belly of digastric muscles.
hyoid. See, I'm going to tell you now. This is big artery here. This is number 11. This is the external carotid artery itself. Okay, very large. It's not just a branch. Okay.
Yes.
Until here, number 11. From here, going here. And these are the branches. 28 is
The first.
the facial, linguofacial trunk. Linguofacial trunk.
Okay.
Okay, from the external carotid, which is 11 here. I asked you regarding 48 stylohyoid. It is from the hyoid to from the hyoid bone to styloid process. So it is a stylohyoid. Okay. And what about number 21? This is strip.
This is posterior belly of omohyoid.
There are superior belly 45 and intermediate tendon and inferior belly. Inferior belly, omohyoid. What is the meaning of omo?
Omo, I mean clavicle. Scapula.
Okay.
Yes, that's part of scapula.
What about number 18?
Can you point it out, sir? 18. Okay.
Number
cannot.
18. This one. Number 18.
Okay. This is hyoid bone.
Hyoid bone. Okay. So
Yes.
regarding what is going to be asked is like, you know, the important ones, but I'm trying to clarify. This been asked before, these two nerves, number 1 and number 16. 16 is superficial to sternocleidomastoid, so it's superficial one.
Okay. Great auricular superficial one.
Yes, the lateral and superficial is great auricular, and the deep medial to sternocleidomastoid is the spinal axis. Okay. Okay. Very good. Good. Okay. Regarding the surface anatomy of the spinal accessory nerve, do you know what is the surface anatomy of the spinal accessory nerve?
Spinal axis nerve, it crosses the posterior triangle of the neck. And between the point of the junction of the upper 1/3 and lower 2/3 of the sternomastoid. To the junction of the lower trapezius.
Excellent. So it is crossing the posterior triangle of the neck between a point connecting the junction of the upper 1/3 and lower 2/3 of the posterior border of sternocleidomastoid to a junction, this one, connecting the upper 2/3 and lower 1/3 of trapezius, nothing more. Okay. What is the boundaries of the anterior triangle of the neck?
Anteriorly, it's the midline. Posterior, the anterior border of the sternocleidomastoid. And superior, the lower part of the mandible.
Excellent. The subtriangles divided by digastric above and omohyoid below, these ones here, you see these colors. You have digastric triangle, submandibular triangle containing submandibular gland, nodes, facial vessels, and the hypoglossal nerve. This is the color. And this one is a muscular triangle containing strap muscles and the external jugular vein. And this color is a carotid triangle containing the carotid sheath, which is containing common carotid, vagus, internal jugular, and outside the ansa cervicalis from anterior. Nerve supplied to digastric muscle. We said the anterior is embryologically first, so it is T trigeminal marginal mandibular or nerve of mylohyoid of the C nerve of mylohyoid of mandibular of trigeminal T, first T, anterior belly of the, and second is S. Second facial nerve is, the second is second laryngeal arch derivative from S7th, which is facial nerve, and pos is posterior. If you remember from part A, if you only remember. Okay. Okay, regarding the posterior triangle of the neck, you have apex by sternocleidomastoid and trapezius muscle meeting at the occipital bone. Anterior, posterior belly of sternocleidomastoid, posterior, anterior border of trapezius, as you see here, and the base is middle 1/3 of the clavicle. And please note that the internal jugular vein does not lie in the posterior triangle. However, the terminal branches of the external jugular vein do. What are the contents of the posterior triangle? We have nerves, muscles, vessels, and lymph nodes. As I have illustrated, you have descent of some nerves like phrenic, accessory, 3 trunks of the brachial plexus, branches of the cervical plexus, vessels, external jugular vein, and subclavian artery, 3rd part. Muscles, inferior belly of omohyoid and scalene. Inferior belly of omohyoid and scalene muscles. Lymph nodes, we said supraclavicular and occipital. Okay. Carotid body and rest of the stuff. Okay, so anyone is here wanted to participate? Dafar, Vayo, Karthik, all of you participated. Anyone wanted to participate? Okay, go on, Dr. Dafar. What are the branches of external carotid?
Branch of the external carotid, the 3 anterior, 2 posterior, 1 deep. The anterior, it is we're starting from the ascending pharyngeal deep, posterior occipital and post-aurical. Okay, with me. Okay. And superior thyroid artery, and ending in the superficial temporal and maxillary.
Excellent. So I need you in the MRCS OSCE to have very quick mind, very quick and very mind with a single sentence to answer.
Yeah.
Where is the carotid body?
The carotid body, it is located in the posterior of the bifurcation of common carotid artery, which have the response to the pH due to have the chemoreceptor.
So BBB, body posterior at bifurcation.
Yeah.
BBB, body posterior bifurcation of CCA. What is the level of bifurcation of common carotid?
C4.
Excellent. So by 4, C4, bifurcation of CCO is C4. And also bifurcation of the aorta at
Bifurcation of aorta, abdominal aorta.
L4, L4 as
L4.
well. By 4, L4 of the aorta. Okay, so it is P, body posterior bifurcation, and pH, so it's chemoreceptor. Very nice. Sinus is dilatation, so it is sensitive to changing in the pressure. Where it is located, it is dilatation already at the base of internal carotid artery, just above the bifurcation of CCA. And it is containing baroreceptors, maintaining the blood pressure. Okay, what are the two terminal branches? You asked the behind the neck of the mandible, inside the parotid gland, there will be division of the external carotid to two terminal branches, superficial temporal and maxillary, as you see here. Okay. Okay, so regarding the previous stations that we increased, I need you to have very nice minded memory to have all stations answered like that. What I have added and what you have added is to be not to know the knowledge, but to make it very nice and clear in your brain. Okay, like that. Okay, so single sentence, and as we have discussed. Okay, because last exam this been asked, and Ola told me, and Isra as well told me, that we are like, we have been confused which is Chuvistock. So we have discussed today about which is Chuvistock, which is Trousseau sign, and I'm keeping it light, but you should study in the background to show the higher pass marks in the knowledge. We can fail in skills, that's fine, but knowledge is very easy for for any student, really. Okay, thank you so much. Keep going, and I will be studying with you according to the schedule as well. Thank you so much.